welcome back to the How I Rehab podcast, brought to you by the Sports MAP Network. My name's Nick Kane, I'm your host. Today we're chatting with Tim Sayers around the ACL and some key aspects he uses within his rehab. We've tried to focus this one more around the female athlete, but clearly it'll be applicable to both sexes and depending on what scope you're working in, and I'm sure there'll be plenty of tips to take away. Now, to give Tim a bit of an introduction, he's an expert in the diagnosis and management of knee injuries. He has a PhD in physiotherapy related to the biomechanics of the ACL and patellofemoral pain. He's a title research physiotherapist and honorary senior research fellow at the University of Melbourne. And finally, he's director at Melbourne CBD Physiotherapy and Sports Spinal Clinic. I've come across Tim, and his approach to what he's doing with some of the ACL work is fantastic in both his research sense, and we tried to tease out here today how we can apply some of that research into those in more of a clinical setting. It certainly has applications to those in professional sport, but if you're working in a physio clinic, you must listen to those working with ACL populations. So I also had a bit of feedback recently to drop a bit of the promotional stuff at the start, so we'll do that. That's dropped. But of course, you can find good courses and access to all our masterclass content at sportsmap.com.au. So always shoot over and have a look. All right, let's jump into this chat with Tim, and I hope you guys all enjoy this one. Tim, welcome to the How I Rehab podcast.
Thanks very much, Nick. Pleasure to be here.
Awesome, mate. Well, we're rapt to get you on board and talk around ACL and some of the research you've been involved in, but also how that's applied clinically, and I guess, and maybe run through a couple of cases and how you might see ACL throughout this chat. But mate, as we like to start most podcasts, we need to get a bit of an idea on who you are and your background and things like that. So please fill us in on that before we get started into some questions.
Sure. So I guess I began sort of my studies as in a Bachelor of Science. So I actually didn't go straight into physio. I went into science and then did a range of different subjects as you do with science, and then actually ended up in muscle physiology, which was kind of a lot of my interest, and had the fortune of working with Professor Gordon Lynch at the University of Melbourne, who's actually quite well known in the dystrophy, so muscular dystrophy research. And that actually gave me quite a lot of sophisticated knowledge, I'd call it, in muscle physiology, and they're testing a lot of, I guess, lab-based studies that would extend to human trials in muscular dystrophy, but that, I guess, has relevance to some of the research we'll talk about later now in physiotherapy. I then transitioned to a doctor of physiotherapy at Melbourne University, which is a standard physio degree, and then had the genius idea that I joke about to go straight into a PhD. So I actually didn't take time off. I went straight into the research side of things, which was related to ACL and patellofemoral injuries, and got, I guess, a lot more training and understanding in biomechanics and human movement. And throughout that, I was also working as a physio. So I guess I graduated and then split my time as a physio and studying through a PhD and learning all the research and getting a bit more of an understanding in the biomechanics world related to ACL and patellofemoral injuries. And then following that, I've had a range of jobs, I guess, in terms of teaching across sports physiotherapy and physiotherapy, both here and abroad in Luxembourg. I had a pretty unique opportunity to go overseas and learn from some highly sought after physios in the ACL world. There's an orthopedic surgeon there who's quite well known in the European Society of Knee Research, and made a lot of contacts as well for research we've since done. And then through my colleague Nicholas Cross, came back to Australia and developed a clinic with the mindset of trying to, I guess, pursue the boundaries in, excellence of care, we'd call it, with sports physiotherapy and apply that across, I guess, both the sort of recreational population, but also the elite athletes.
Nice. And who are the experience in Luxembourg? Fill us in a little bit about that, and maybe who a couple of those, the names, I guess, that you sort of called on and that were the key experts there for you.
So there's a professor called Professor Roman Zay, who's a really renowned researcher in ACL surgery techniques, and their group through the Luxembourg Institute of Health. Do a lot of really fascinating research to do with conditions that I probably never gave much thought to in ACL injury, and that's ramp lesions and really complex type of meniscal tears that often get overlooked in ACL surgery and can be why patients, particularly at the high level as well, maybe have an ACL graft failure or report persistent instability and pain. And often it's not until you actually do an arthroscope and go in, or sometimes you can find them on MRI now, is the ramp lesion can be repaired and can be identified, and it's a major problem in some ACL populations. And so he was sort of one, I guess, person that was quite influential. And then there's a number of other academics. So Roland Croquet was another person that I was a bit of a mentor of mine who was wonderful in the physiotherapy context. And then a man called Daniel Tyson, who's if you look in the literature around knees and injury prevention, his name is through a lot of this stuff. So I guess collectively they sort of give me different aspects around injury prevention, surgical techniques, and I guess just more normal sort of sports physiotherapy and how it's done in Europe, which is quite different in many respects.
Yeah, cool. Can you tell us what a ramp lesion is, and I guess maybe a couple of those other sort of complex meniscal tears that you sort of mentioned that we can get stuck with, just to kick us off? And
sure. I mean, I guess the classic sort of meniscal tears that people talk about are like a buckle handle tears, and you see like in your standard MRI report around radial tears. But the ramp lesion, so the ramp is the sort of junction at typically in the posterior horn. We see this with an ACL tear. And so the posterior lateral corner region is often involved as well. And so the ramp is the slope, if you like, of the back part of the meniscus, where you can often, due to the rotational load that goes through the knee, you can basically tear through sometimes the posterior lateral corner, but specifically the ramp that is kind of like the junction between the capsule and the meniscus in the posterior horn. And so they can sometimes be really minor and heal on their own to do with blood supply. Sometimes they can extend right into the joint centrally, and they're not typically picked up on MRI if they're really small, because obviously your signal or your hyperintense signal around the posterior horn, sometimes it's not quite enough. And it's a bit of a guess as to whether the clinical symptoms of the patient are actually related to any of the signal in the posterior aspect of the knee. So they often go in, and basically sometimes this is how they found them, pretty much, is that they were going into to do an ACL reconstruction or investigate, and basically found that there's a really high prevalence of ramp lesions in the posterior horn when they basically went around the back of the knee intraoperatively and found that there were these meniscal tears that they repaired, and have since done studies to follow up to show that those that they repair get a lot better. So it's one of those conditions that I think if you've got an ACL patient, or even, to be honest, just a patient with a meniscal injury that's just not getting better and it's chronic in nature, they really struggle with, it can be even as simple as running or triple extension type work, deep squatting. It's really quite varied in terms of the movements. Then consideration of ramp lesions is often not the top of the list for most clinicians, but can be actually quite important, because it's a critical part of the meniscus's hoop function to absorb and transmit load, and often it's overlooked. So it's something to consider.
Okay, is that something that can be missed sometimes with the initial ACL? So if we're talking, now I'm getting pain for 6 months later, but they've had a reconstruction 4 to 6 months earlier, is that maybe sometimes often missed in the surgical pathway early on that wasn't picked up, and we need to be aware of that later?
Yep, and that's exactly what I think, from my knowledge of what happened with sort of discovering them, is obviously the primary concern initially with most is ACL injuries is, are we going to reconstruct? And then they reconstruct and they go in and they obviously do the ACL reconstruction. Maybe there's a larger meniscal injury there at play. They repair that, but they never really considered going around sort of to the posterior aspects and really investigating it. And sometimes they're probably not there. Sometimes they might develop, as you've said, sort of 4 to 6 months later, and they have this sort of chronic adaptation, if you like, or change in knee function. And that may be partly due to different mechanical patterns that are going through the knee across that 6-month period. You've got a different graft in there as well, and you've changed, I guess, the loading or the distribution of load across the knee, and so sometimes they develop, but I think from my knowledge, majority of them exist from initial injury, and it's a bit like the posterior lateral corner. It sort of masquerades in the background. It won't give you significant symptoms like an ACL that's unstable will. It'll give you this sort of vague discomfort, maybe progressive instability in the knee, and the feeling like the patient just really struggles to maybe push laterally and pivot and shift the way they would and cut on some of their field-based movements. And it's then sort of that further investigation you go through that you tend to find them just because they're not really functioning at that high end.
Lovely. Well, that's a nice one that we hadn't really planned to go through, but great to sort of
that's right.
A great little clinical insight there for us not to miss. Let's jump into talking a little bit around your research,
Sure.
and then we'll sort of look to bring that into some clinical aspects and how it all ties together. But yeah, some of the great research you've been involved in has been around musculoskeletal modelling and the ACL landing forces, predominantly in the female athletes. Fill us in a little bit around this and your findings.
I guess for those that probably are not aware of what musculoskeletal modelling is, I certainly didn't know much about it many years ago, and I think I've come to appreciate it a bit more now. And I think it can be quite valuable for clinicians if you do understand, because there's more studies coming out around this in various areas. Essentially, it's transferring a lot of what we have done for many years in biomechanics. So your sort of classic force plates, marker setup, getting a patient or a participant in research to do your classic movements, whatever they may be. So in our case, it was what we call a drop lateral jump, which is basically jumping off a botch and then jumping either left or right. So it's a kind of like a lateral pivoting, shifting, cutting type of standardized task. And we've extended that then to running as well. But you could basically do any task you want. And it's transmitting the biomechanical data that you get through EMG, again, your joint kinematics, so looking at the joint angles, your joint kinetics from all your force plate data. And then if you go to a really sophisticated level, which we haven't done yet, but we're hoping to do in future research, you can start to put MRI and do subject-specific modeling on top of it, which looks at fascicle length, tendon slack length, tendon strain, and it gets pretty sophisticated. The output, though, essentially is that you can get a much more accurate representation of what's happening at joint and muscle. And the variables you essentially get is muscle force output, typically in body weights, and joint contact force, which is essentially a combination of compression and shear through a joint. And you can segment that then into medial and lateral compartments, patellofemoral. So we've shown that, and then I should probably mention that you can also now model ACL load. So what we've shown is with female athletes, obviously they have a higher risk of injury of ACLs. And we did ours in sort of two different ways. We've looked across puberty and looked at the growth spurt, because they tend to be much higher through adolescence and into that early sort of female athlete. And we tend to see that because of growth in a young female athlete, or just generally, I guess, in young females, the exponential growth in long bones changes mechanical patterns around the knee. And so they do tend to start to load the knee into flexion and what we call abduction adduction, which is a varus valgus motion, to a higher magnitude that theoretically their muscles are not able to control. So because we have this sort of delay in mass and volume of tissue to catch up to the skeletal bone length, that's one of the things I think the reasons we think that the female athlete, typically in that sort of 12 to 17, 18 range, tend to have a lot more ACL injuries when they're playing a lot more contact or rotational type sports. So netball, AFLW, these type of things. And then we extended sort of the research from that to look at ACL load, in which we found that the majority of ACL load is actually in the sagittal plane when you jump off a box. So think about like your plyometric type of movements that you would typically do in a clinical setting. If you have any kind of component where you drop down and try to cut off the box or simply drop down, from our calculations in terms of the modelling approaches, it shows that 95% of that ACL strain or load is in the sagittal plane. So while people sort of think of the rotational capacity of the ACL, it is important, certainly. It's part of the mechanism of injury, but arguably it doesn't tend to provide a significant amount of strain to the ACL when you're doing these broken down tasks, which essentially leads us to think that the sagittal plane mechanics are actually very important, and to consider that when you're completing rehab as well.
Okay, interesting. So, I guess what would you advise around? Is there a pick for you to, if we're going to analyse some of that sagittal plane mechanics for us in the clinical world? What would you advise around that, and how can we tease some of that information out of that?
I guess this is the real challenge. It's and we've kind of developed this in our own clinical context over a number of years. It's why we've sort of bought particular pieces of technology to try to help us answer those clinical questions. That's not necessarily research grade. So I guess in one context you could use, if you have available to, certainly you can look at kinematics. Having said that, there's quite a bit of error in it, and it doesn't infer what's actually happening at a joint level. So if you, for example, get an athlete to jump off a box, like I said we did in research, and you have some kind of sort of wearables or devices that would measure the knee flexion angle, ankle, hip angles as well, you could certainly pick up change, and it's certainly an important aspect. But I think the limitation with that is, well, what you're not measuring is the why, and the why is actually probably more of where we've started to go into in terms of our clinical reasoning, which is the muscle load is actually, and the muscle tissue sort of contribution to each other through that sagittal plane of the quadricep, soleus, gastroc, are actually more valuable to us initially than looking at the kinematics of how someone jumps off a box. And so what we tend to do is actually the strength that I'm sure many clinicians look at. We would look at the overall capacity of, and when we talk about capacity, we're talking about the peak force output in a Newton meters per kilogram measurement. So there's quite easy ways to do this in a clinical setting. So not just looking at sort of the classic left versus right and the symmetry index, we're actually extending it further to have a look at peak torque relative to someone's limb length, someone's body weight, because we've got some pretty good data out there to show what normative data looks like for male and female athletes of certain age groups. And there's some really nice data from one of my colleagues, Nicky van Melk from Netherlands, who's put out a lot of data on this. So there's if you sort of batch a lot of this across those areas, you can get these values that we've come up with to use in a clinical setting. And so again, something like a quadriceps isometric contraction at 70 degrees of flexion we use. We then use, which many people do, is the standing isometric rig, so Vald and the like, that you can measure, I guess, a component of calf load. And we have essentially thresholds for whether that tissue has the capacity to be able to absorb the load in the sagittal plane. Because we find that, yes, you might find the kinematic changes, like we mentioned. You might have wearables that are useful in that context. But the why, you kind of get to the measuring the patient's knee flexion or trunk flexion angles, and they're different. But what are you going to do to change them? And if you just go down, this is our argument, down a neuromuscular or a neuromotor training pathway without first considering the actual capacity within those tissues to absorb load in the sagittal plane, then I think it's a bit flawed, and it's a bit sort of mixed in terms of the priority of what we've got to deal with first. So quad and calf basically is where we start, and then we would extend from there.
Yeah, that makes heaps of sense. So if we stay around the female athlete, we haven't had too many podcasts where we've talked a little bit more in depth around the female athlete with ACLs, and we know how prominent they are and how topical. And obviously you've gone quad calf there. Can we break down a little bit around the testing a little bit more? So you mentioned that the calf rig, but let's maybe start with the quad if we can, and tell us how you might test the quad and maybe a bit of normative data around that, thinking that female athlete, and then and then break us
Sure.
down into the soleus and gastroc if you're happy to.
Sure. So quad, so we initially started, which again, I think from my awareness, many people probably start to use, is the isometric. We use 70 degrees, and we use that for a few reasons. Peak torque is generally around 60 to 70 degrees of knee flexion if you're doing an isokinetic test on sort of Cybex or some of those sort of research grade return to sport testing machines that I'm sure many people are aware of. You look at your curve, and your peak torque tends to be around 70 degrees. We set that rig up, or that position. We actually initially did it with the valve dynamos with a strap tied to a plinth. And I know there's various ways that people do this, and basically lock the plinth so it doesn't bend or flex, because we found initially that was a problem. And there is a limitation to, I guess, the patient moving a bit, but we get a seatbelt and strap them to the plinth, and then literally use a goniometer or your device like your phone to measure 70 degrees flexion where they're pushing, and basically get the raw output from that and do left versus right. That's where we started. We then went a little bit further, and we've since bought some I guess more sophisticated equipment in a Kineo intelligent load from Italy, which now is a bit like your Cybex and those isokinetics, because we can do both isokinetic testing now and isometric testing. What we look for, though, irrespective of whether it's sort of a fancy machine, let's say, versus your dynamo in a clinical setting, is for female athletes, we look for 2.5 newton meters per kilogram. And that's pretty well shown across a lot of the strength testing data, whether you look at sort of dynamometry data in various athletes and various populations. I think the key here is that most clinicians wouldn't spend the time converting it, either because maybe they're not aware of it, not sure how to do it, and what numbers maybe they should be using. And we've found most of the time, if we actually stick to getting an athlete's quad numbers above 2.5 for a female, then their quad ordinarily is not actually the issue if they've got, let's say, knee pain or other issues within the lower limb. We just take the Newton output from the dynamo or devices like that. We measure from your medial condyle to where their force application is, which is your lever length. And then we multiply by the body weight in kilograms. So you can actually do a really simple conversion to Newton meters per kilogram, which is essentially like a research grade. It's a normalized calculation now that we can utilize for quads. And that's where we started. I guess then we extended it to calf, and calf's very tricky. And we've, in many contexts now, used a bit of sort of Alex Natira's work and Danny Lum, and used, I guess, some of the isometric data that they're putting out through VALD. We tend to find, again, when you put someone on a forced deck, for example, and you get them to do an isometric contraction, height's really important. So obviously how much plantar flexion. So if you can standardize that, we tend to standardize people around 2 to 3 centimeters off the deck, through the heel, that is. And we don't lock out the knee. We have them in like a touch of flexion. So not the knee iso push that most people would be referring to. That's obviously where you've got the foot planted on the ground. This is actually, it's a more upright position. And when you get the output from that, it tends to be in peak force as body weight, but you have your body weight of the athlete superimposed on top of the active force that they've produced. So the output might tend to be 2.5 body weights worth of force. And that's kind of like the system load that people talk about. You could use 2.5, but actively we talk about 1.5 for a recreational athlete, female-wise. 2 is really good. We have athletes in track and field, though, that are sort of 2.5 and 3. So it is a bit of a varied scale, but I think the absolute minimum, if you've got an athlete that's at whatever stage of competition or level, to be honest, if they're returned to sport and you think they're ready to go running and they're producing less than an active 1.5 or a total on the plates of 2.5, they're arguably going to be in trouble, because the calf plays such a critical role with knee load. It's often overlooked. Everyone talks about quads and hams. Calf is, I would actually probably put it up just as high as quad, if not sometimes higher, because it's so critical to function with transmitting load through the knee and offsetting that load when you jump and land and pivot.
Yeah, nice. I can really visualize what you're talking around there. Can you just break us down a little bit around the 1.5 and 2.5 a little bit more? So the active. So what do you use? Do you use what it would spit out with obviously accounting for their body weight, saying 2.5 being your target, or how do you get the 1.5?
Well, so the 1.5 is literally just take a body weight off. It's really pretty simple because the way that the plate's calculated is obviously you go onto the plate, it measures you as a calibration, and then that 70 kilos is 1 times body weight for that athlete. So when it computes the data to the peak output, and that's probably one of the important things, is that the recording of your, and depending on how you've set it up, I'll use Vaulted as an example, their automation typically increases once you've hit above 20 newtons. So it'll have a baseline, and that baseline is the body weight of the patient when you're on the plate. As you start to push into an isometric, as soon as the curve reaches above 20 newtons as a default, it'll start recording. So it's actually quite important that you do spend the time with an athlete and actually have that baseline body weight nice and still before they push. I know plenty of people just sort of jump on the plate and they might just ramp it up. But if that curve is going up and down, then you're arguably that 2.5 could be variable because of where the actual curve has been calculated from. But 2.5 is essentially what we use. And I guess in male athletes, it obviously needs to be higher. At the moment, it's 2.5 though. So I can just convert it back to 1.5 by taking a body weight away.
That's fine. And males, you're saying got closer to 3?
3. Yep. Above 3. Cool. So 2 body weights worth of active force.
Okay. So when you're talking to muscle function, I really come back to the stuff you sort of mentioned at the start around, the muscle forces. We've gone through the quad and the gastroc there. Do you do the calf work in a seated position to target soleus, or you're comfortable getting what you need out of the test you've just talked about?
We don't actually, and it's might be sort of counterintuitive. We tend to find that, I guess, the question that we ask, and coming back to sort of that why, like, has the athlete actually got the capacity within that tissue as a whole? We could certainly sort of delineate that further into gastroc sort of soleus bias, but there is some literature sort of around the fact that soleus is actually pretty active when you've got someone in standing as well, and arguably, again, from a functional point of view, they're going to be in standing or that sort of triple extension type of position for knee-related conditions when they push vertically and jump and change direction. So it's not that it's not worth doing from our perspective. I think from my perspective, it's certainly a good test to do, but we don't actually use it at the moment because we find that if we tick off the boxes of quad, as we talked about, calf in the standing position, but then actually go further around sort of pelvic strength, hamstring strength, and then if those are all right, then we move into sort of the next stage of maybe, like we mentioned, jumping assessments or kinematic assessments. Then that's kind of the better way to I think, structure your assessments.
Yeah, lovely. Well, you stole my thunder there because I was going to ask around hamstring, but love to hear a little bit around that. And obviously, you mentioned pelvic, and maybe just breaking down how it looks, if that's referencing hip extension, or are we talking a lumbar pelvic measure or aspects like that? Would be great.
In terms of hamstring, we currently do it on our kineo, so we actually have the fortune, I guess, of doing a standing isometric hamstring curl, so which is quite different. So not the standard seated hamstring that you might see with an isokinetic machine. The angle we use is around 20 degrees. So we typically lock the machine at 20 degrees because peak torque tends to be around, again, from curves that we've analysed and research, tends to be around 20 to 30 degrees. We've found 20 works a bit better though, so we've stuck with that. In terms of previous to that though, we've done it with handheld dynos, like I'm sure many clinicians would do. I think the key criteria here is if you do have a handheld and that's your only way of measuring hamstring, the key is to actually get the hip into a bit more flexion. So I know we've had a few discussions with Craig Purdom about this as well, because he's obviously very knowledgeable in this area. They used to do it at the AIS, from my understanding, with a bit of hip and knee flexion to try to get more hip extension, for testing hip extensors, but also for hamstring. And we've found that, about 20 degrees of hip flexion with 20 degrees knee flexion is the best for the hamstring because of its dual sort of roller across the hip and distal knee. And so you can, like, a really simple way of doing it, for example, might be to put a foam roller or something, if you've got a big enough one, to try and under the pelvis, to try and pop the patient's hip up in prone into 20 degrees of flexion, and then obviously have them hold the end of the plinth and pop them down into 20 degrees with a measurement. And that's kind of the best way, I guess, you could crudely measure the isometric capacity of the hamstring in a clinical setting. The same procedure for us, though, when we use sort of the machine, it's obviously a lot more robust, but we use the lever arm, so you can still measure from the knee joint axis, so from the medial femoral condyle down to where you're applying the force. So you could just standardize that across the medial malleolus, and you just measure it with a tape, and then take the athlete's body weight, the newtons output that the dynamometer would give you, or the machine, and away you go.
Lovely. And anything around that covers off really well, I guess, around some of the muscular component and testing. The other elements around the hip and pelvis, is there anything that you think is really pivotal there that we take note of?
Again, if we're being robust, I think it's worthwhile considering certainly a adductor, abductor, hip extensor, hip flexion function. And I think the key, this is what we do clinically, and there is a bit of research in the hip and groin world around this, but balance within the pelvis is probably one of the first things that we actually find is really important. So we really look for the synergistic action. This is coming back to biomechanics as well. So if you think about your synergists within the hip and groin region, or hip and pelvis, so that hip flexor and adductor, particularly adductor magnus function, is quite important. And likewise, your hip extensor hamstring function is quite important. And they will, throughout the gait cycle across running and cutting, will sort of, from a synergistic and antagonist point of view, are critical in terms of how they transmit load through the pelvis. So we measure hip flexion in neutral, so like a 0 degrees hip flexion over the edge of the plinth, which I think has been done in previous hip and groin research. As a screening with a handheld, pretty simple. We'd look at the standardized stuff, so hip abduction, inside lying, and sort of your I think it's 60 degree adductor squeeze position. And then hip extension is an interesting one. Most people are actually pretty strong, so it's actually quite hard to do in prone. We would tend to try to use the same position that I mentioned before about hamstring, so have them into a bit of 20 degrees of hip flexion. This time you just bend the knee up to 90 degrees and put your handheld dynamometer at the posterior aspect of the knee, or the distal hamstring region. The but there is that most athletes will overpower you for hip extension function. So that's where we actually have a kineo I mentioned before, which enables us to do isokinetic and isometric function in the leg press. So we can actually put someone into 90 degrees of hip and knee flexion, or get them into a really deep type of squatted position, single leg. And while there will be contribution in that position from quadricep and other muscle groups, primarily you're going to get a lot of adductor magnus and glute. And there's not a lot of research. It's something that we're actually sort of looking more into. But we look for peak outputs through a really deep position through the kineo isometrically. And in this sort of context, we compare, obviously, the left versus right. From a literature point of view, there's this, I guess, a bit of an understanding there might be around a body weight worth of force needed in that position, but it's really limited. So that's kind of the area that we look for in, or the way we sort of look at hip and groin and pelvis, but more to be done.
Mate, appreciate your sort of openness and willingness to like talk through that, because I know, like, you know, it's brilliant to be able to get some context around the clinical aspects, because we know if we had all the money in the world, we could do all these things, but then most of us don't, and how we can actually try to tease out some really important information to help profile and see where athletes sit. It's really great to hear. what you're doing there. So that's great. And I know, the research you've talked around there around the female athletes and how you then apply that, it's really coming through into what you're doing, I guess. So yeah, in taking that area, I know you mentioned the next aspect around what you might look at is some of the jump data and that sort of thing, and then you process from there. What do you sort of follow up on there? And I sort of bring in this thinking, here's a case, as in I'm bringing an athlete to a female athlete. She's had an ACL before. I'm having trouble with what's going on. I'm not quite getting it. I'm not being able to get the quad. I'm not seeing the transference into my jump data. I'm all of a sudden a little bit lost. What would you be sort of looking at aside from the stuff we've just talked through there?
Yeah, I guess so. If we've considered the capacity, if you like, or the strength capacity of the tissues within the lower limb, certainly we then extend that to your sort of force plate analysis that most people would look at. I just think it's important because there's a lot you can test on force plates, and so it's worth sort of in some ways reflecting on what is it that you're actually testing with the force plate, because we can sort of get ahead of ourselves, I think, a little bit with some of the force plate type of movements that we would analyze, and you can get information overload pretty quickly because of the variables that a force plate can put out now. So I think the propulsion function, which is sort of a derivative of power, the counter movement kind of jumps would be relevant in this context, purely just for does an athlete have the capacity to produce force? And more importantly, I'd argue that it's the single leg is actually probably a bit more relevant than the double leg counter movement jump that people often do. Counter movement double leg is really just a gross measure of absolute power in the lower body. And you might see transference of load between an affected and unaffected limb in that female athlete. But again, you'll see it much, much more when you do it in a single leg context. So I think we would certainly do your single leg counter movement, the single limb drop jump, because the difference mainly between your single limb drop jump and single limb counter movement jumps will be the absorption, I guess, of load of the drop jump relative to the concentric or the power development that you'll get from a counter movement. So they're testing kind of different components of a running gait cycle or a cutting cycle. And I know sort of many of your listeners and yourself would know all about that kind of data with all the conferences that you've done in terms of force plates with endo and the following. So I think they're probably the two main tests that we would look at. And then from our context, you would obviously blend that with the clinical assessment. So like we talked about at the start, like ramp lesions, all this other stuff that many people don't consider. Like you need to go into much more than just a Lockman pivot shift, anterior drawer, some of these really basic tests, go into posterior lateral corner assessment, laxity, even consider things quite sort of easy in a way, which is compliance of a hamstring tendon, because you can actually get a bit of an understanding that someone's had an ACL graft of the hamstring. And the compliance within that tendon clinically can be actually felt when you go through and assess how much sort of manual strength can you put through it. And so you can actually feel the compliance is different between that left and right limb. And these little bits of information will also feed into why, as you said, maybe there's that female athlete that's struggling at 4 to 6 months down the track. While we've considered strength and some of the biomechanical aspects of jumping and loading, some of the really in-depth clinical, I'll call them nuances, will also be quite valuable as to why they might be struggling. And I guess the last sort of component to us is we're a bit crazy because we're a bit data savvy and data crazy, I should say. We extend that to something like a 1080 sprint, which is basically I call it an expensive piece of string, which is basically a device where we can actually now measure your left and right contact times and power development through every step, accelerating and cutting. So basically you get them to accelerate over 10 or 20 or 30 meters, go right up to 100 if you want to, but really for these athletes, we only care about the first 30, 40 meters. And we actually see what their function is actually kind of like in the field. So that's kind of the sort of progression, I guess, that we would look at.
Yeah, that's cool. I know your colleague Nick does a fair bit of sprint stuff. And look, you don't see a 1080 sprint floating around too
No.
much, other than when I've popped into a couple of NBA clubs and a few other things. They are a
Yep.
pricey piece of equipment. I've had a quote on it, and unfortunately, we couldn't get
Yep.
it over the line where I work. But you've
Yep.
managed, so it's
They're
good
not
to know
cheap, as I
you've
said.
you've got that.
I give
So
him
for
I give him a lot. I say, "Look, this is the most expensive piece of string." So
well, for
um,
listeners that want to get some good feedback on some of their acceleration and sprint data, it'd be a nice place
yep.
to visit and come and say good day to you guys down there. So that's okay.
Yep.
That's really interesting. Um, I'm sort of just this, the stuff we've gone through here is like brilliant from a physio standpoint and where we want to break things down. And if I'm obviously around the female athletes and we're having the ACL issues, talk about prevention, maybe just like later stage rehab and things like that. From an exercise selection and where we go with that, we're talking around getting that peak force and that capacity measures. Do you see, I guess, the people you see, are they training well enough in to build that muscle? And is that part of the problem? So that from the competitions and the athletes you see, and to be able to get that capacity in those measures where we really need it, is there anything you do that's maybe different, or your key areas of exercise selection that you go for that you think are like paramount and really important to give us what we need here?
Yeah, I mean, generally speaking, most people that I see, and I guess that we see from an athletic perspective in females, will have an element of they probably haven't been pushed enough. So they probably weren't, and we see that through like we talked about, their muscle force or the peak force is still quite low relative to where we want to see it. So that maybe the exercise prescription or in some contexts wasn't quite high enough. And this is not to say it shouldn't be used, but the sort of standardized kind of programs that are written, I think, are probably not addressing how high you actually need to go with developing their strength and then integrating that into the new motor function of return to running and sport. And so, to give an example, and I'm going to very much generalize here, is the context of sort of a squat, deadlift, RDL, those kind of things into maybe sort of single leg knee extension, hamstring curl is quite simplistic. And it doesn't necessarily translate to that function because your sort of maximal voluntary contraction of the muscle tissue and the type of contraction of that tissue relative to what you're going to get them to do in return to sport is probably not matched. And so I think isometrics have a big role here, both from a tendon component, from a motor perspective, and from arguably, I guess, a function perspective. So we use quite a lot of, early on even, we use quite a lot of isometrics to develop the tensile load and the stiffness and try to, obviously we can't measure it, but we hope to be transferring early on a lot of that collagen from type 3 down to type 1, hopefully, or a mixed collagen presentation in a hamstring graft. So a lot of hamstring isometrics, a lot of knee isometrics, a lot of standing calf isometrics and knee isos. And we then obviously would facilitate that into other isotonic exercises. So you can obviously then go for early stages, for example, blood flow restriction training is great to try to get some volume on of tissue. You standardize sort of open kinetic chain knee extensions. The one thing I'd have there is you should be measuring though what that peak output is, because if you just say, oh, let's just tick the load up on a leg extension, you actually don't know relative to their maximal capacity where they're actually training. So if you can do something like what I said before and actually measure the 70-degree leg extension isometric, obviously at a safe point in time, like say we're going to be sort of much further down the track from surgery, then you can use that as a sort of a crude measure in some ways, as a maximal voluntary contraction. You can prescribe their load from that for leg extensions in an open kinetic chain. So they're hopefully getting into that strength range or that hypertrophy range that you actually want, rather than just what many people do, stick them on the leg extension and tick it up as they can and program it accordingly. I guess then sort of extending further, we'd probably go into a lot of neuromotor training. So I think pulses, which we see a lot in the Achilles tendon research, I think this is quite fascinating because you'll get the athlete that basically doesn't move that well. Like you either measure it from a jump or you watch them run And you know that from a kinematic or the way they move, you get that impression they're just not moving well. They're compensating. They've obviously using their hip and trunk more than their knee through flexion. They're the athletes that typically they might be actually reasonably strong, and you measured that, but their neuromotor function still has considerable deficits. And so it's quite interesting if you get, there's a version of leg press pulsing, which is quite a unique exercise that, again, I was introduced from Craig Purdom and a few others in that tendon area. But it primarily tries to actually get the central nervous system to actually fire at a frequency or a hertz rate that's similar to running and jumping. Because often if you just stick it, the old sort of adage of like slow and heavy, then they'll be slow and heavy. Well, there's a bit of that because the rate of force development, the movement patterns that's required from the central nervous system at a return to sports stage is far, far higher than your heavy slow. So yeah, things like your calf pulse, your leg press pulse, your leg extension pulse, and hamstring pulse, believe it or not, depending on, again, what you think is the deficit and in terms of how that's going to improve their movement that they might be struggling in, we integrate a lot of that on top of the standardized sort of strength and conditioning I mentioned.
Okay, hope you are enjoying this podcast with Tim. And I did say I'd drop the promotion stuff at the start of the podcast, so we thought we'd just sneak it in midway through. And that's purely just around our soft tissue conference in Melbourne this February. We've got an all-star lineup, including Seth O'Neill, who's also doing a couple of workshops either side in Melbourne and Sydney on the calf and Achilles. Seth is an expert in that space with the Achilles tendon and calf complex. He's from over in the UK. Looking forward to being in the UK, in Manchester for the difficult foot and ankle, a highly practical course, and that's going to sell out. So really excited to bring that one to the UK population and physios over there. And then finally, obviously, the masterclass content continues to sort of come through every month. We have Seth O'Neill about to be released, Callum Ball around pec ruptures, and obviously we've had some tremendous ones around the foot and ankle complex recently with Colin Griffin, Shane Kelly. And encourage you to head over and check that out. We are now registered for CEU in the US states. So that's on the back of our course recently over in Los Angeles. So really happy to bring this content more for the CPD learning in the US. All right, head over to the website if you want to see all that further, but let's get back into the chat with Tim. We'll stay on pulses for the moment. So around the hertz, and the frequency, I think you mentioned, say, let's stay with the leg press pulses or the leg extension. Are you, in the calf, we've done the metronome as a guide,
yep.
And that sort of
so
thing.
Same thing.
What are you doing around metronome pulse? How long would you typically do it for? And what sort of load would you be looking at from a percentage of maybe max voluntary contraction on the leg press, as an example?
So there's a couple of buts to this. And so I guess to answer your question, though, we tend to use a metronome because it will be variable between what a patient can adequately control. So obviously quality is important here. The range is really important. So you actually don't get them going through a large amplitude. It's literally from around sort of, let's say, 5 degrees knee flexion, so just flexed in a leg press. And this is more of a horizontal leg press position, through to about sort of 50, 60 degrees of flexion at most. So it's trying to get a rhythmical pattern. So I kind of describe it to patients. Do you remember back in sort of your maths classes what a sinusoidal curve looks like, which is basically that rhythmical up and down? They kind of get it in that respect, some of them. But then we basically program sort of 80 beats a minute, and we might increase it from that depending on how well they can actually keep up. And actually, they're essentially trying to concentrically contract on the beat. And then in the off beat, relax and then be ready to push again. So if their beat's going beat, 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 they're basically going on the beat, not off the beat. And what you'll often find, we go across 20, 30 seconds. You'll often find that they start with it and then their motor pattern completely changes and then they become jerky. And that's the classic patient that if they do a lot more of that, things like drills when you're getting them to return to running or on the field again as an athlete become so much easier. And if you reflect on any athletes you've had that are really awkward when they get back to moving again and you just can't figure out why, I would say it's probably because they're really struggling with the rate of how quick that movement is. And so you would, for example, with a leg press, crank it from 80 right up to 120, 130. And if you can get to 140, 150, great. The but I was going to mention, though, was when you're getting really high frequencies, a standardized weight plated machine doesn't work very well at all, because the foot can come off contact because you've got inertia within, or much higher inertia within the force plate. So that basically means you've got a higher amount of force to actually get the plate moving. But then because of the momentum of the plate, it can come off the patient's foot and then slam back into it. Not ideal for this type of movement. So we have pneumatic machines from Kaiser, which works really well because you can never get your foot off the plate because of the nature of compressed air. Ways you might address it, though, is this is where maybe, I haven't actually tried this, but power bands or the like might actually be suitable if you can set them up in the right position, or even doing a standing quarter squat pulse, believe it or not. So Craig Purdom actually again showed me that. It actually works quite well as you get them in this sort of standing position, metronome on, and you get them to pulse up and down for 20, 30 seconds, two or three sets of that, and you actually get them to do it every single day in the absence of pain or swelling within the joint, because again, it's a motor pattern they're trying to train, and that's actually a pretty good sort of alternative instead of the leg press.
Nice. I never miss an opportunity for a plug. I know you mentioned the calf. Kevin Lieberthal did a masterclass for us on the calf, and he's obviously been involved in a lot of that research and goes through a lot of that pulsing around calf injuries. Swinging back to just your isometrics, and I gather from what you're saying, then those sort of isometrics will be, more shorter time, high force type isometrics rather than our longer that we might have been through before around some tendon stuff, 30 to 40 seconds, however that may. But don't let me presume what you're talking about. What sort of prescription and how you're going around that with the early loading and isometrics? Maybe sticking around quad hamstring targeted sort of stuff.
Yep. So we tend to, let's hypothetically say early on someone's sort of 1-2 months or very early on following an ACL injury. We tend to then do longer holds of 20, 30 seconds. So not like your standardized sort of 30 to 45 seconds, and tend to do sort of 2 to 3 sets of 2 to 3 reps. So we try to stick in around this, again, comes from Natia and Danny Lum, 1.5 minutes of isometric holding time roughly. Obviously evaluate clinical symptoms to see if there's any significant change. Doing them frequently, we would do that in the early stages probably quite frequently because they're limited with all the other exercises they can do. And we do that for leg extension at typically 70 degrees again. We also then transition to a 30 degree when the time's right, basically, because we want isometric stiffness for 30 degrees in that position for function in standing. And then with hamstring, we do it at 30 degrees. For some patients, we start at 90 degrees or 80, 90 degrees, because it's obviously not as much tensile loading through the hammy. And then we transition that. So as they get better at that and they're starting to do more exercises, we've got to be careful of central fatigue. So we tend to drop off the holding time down to about sometimes even 5 or 10 seconds, really focusing on rate of force development. So for an example of a hamstring, so a GHD, for example, we've actually got, the Iron Edge GHD, probably similar to many other GHDs that are available. We actually lock them into, again, about 20, 30 degrees of knee flexion, 20 degrees of hip flexion. We then actually get your handles from your cable row machine, because we've got the hooks below, and we actually lock the hooks there, and we actually try to constrain the system. So the athlete actually basically pulls with a locked, so they basically fix their elbow in extension, and obviously they've got no shoulder complaints, then we can do it, but then their shoulder's fixed as well. And that way you can create a lot more rigid load, if you like, or force generated through the hamstring, because the system's basically locked into the GHD. Without the straps or the handles being held, if you get them to pull really hard quickly, they've got nothing to resist them, so their trunk basically goes up into extension. So that's actually a really nice way that we get the patients basically to go on for 5, ramp it on, and then ramp it off for 5, then ramp it on for 5, then off for 5. And again, we would probably only do sort of at max 4 to 5 of those in a row, no more than 2 or 3 sets. So we actually keep the volume of that pretty low, but the intensity very high. For quad, we would tend to actually transition to a bit more of the standing isometric calf type position and the knee iso push that many people are probably aware of. So we actually don't see the need to do a lot of on and off with the knee extension, the knee at 70 or 30 degrees in that sort of knee leg extension machine position. Doesn't tend to work that well either.
Yeah. Okay. Cool. That's awesome. Let's obviously we're getting to the end of things here, but this has been really insightful. So it's been a great chat. When I'm going to bring us back a level, and let's just say, I guess I don't work in the Australian rules football women's program, but obviously I'm closely aligned to it a little bit. And obviously the program's there, and there've been some fantastic research around play-to preparation, and we do jump and landing and different things like that. I guess if I was to scale everything right back, and I just said, all right, we need to try and prevent the ACLs. Our first step is we would say we need to probably just get things stronger within the systems. Is that fair to say? And then is there, I guess you've sort of outlined around our testing and targets, I guess, but even just a basic, leg press, and you mentioned some of the other modalities of exercises. Do you have a couple of examples for us around just strength targets you would expect them to be able to execute within a gym program that gives us inclination that, hey, we're actually getting that muscle system going? And if we're not maybe at that level, then all the other stuff might just, not really be helping us as much potentially.
Yep, sure. I think, like you mentioned, I think I'm a big advocate for the tissue because of sort of, I guess, my background with muscle physiology as well. I think the tissue has to be prepared to be able to meet the demand of the activity. So the injury prevention programs that have been out there, I think, work for what they've been found to be helpful for because of the neural function, so the neuromotor training, and the capacity to sort of warm up and the like, train the correct patterns of movement. But the limitation to that, and that's probably potentially, I think, why people still, or some athletes still go on and injure, is because the capacity of the tissue to the game of AFLW, for example, the length of time, fatigue, it just doesn't have that capacity to tolerate the consistent type of loading. And so, yes, coming back to sort of the strength, you certainly should be measuring it, and you certainly should be addressing it pre-season or throughout season as well, to try to minimize the risk of that happening on top of the standardized ACL prevention programs that I'm sure are in place. In a gym setting, so we used to do this, it's probably sort of obviously transferred now across to more sophisticated technology, but the triple extension function is really important. So a leg press that's a horizontal function, not a incline leg press, because obviously the incline is going to be a lot more hip dominant. 2 times body weight is where we'd be generally going for at a minimum. And the reason for that is there's a bit of a correlation across to the vertical ground reaction force in jumping and landing. I guess it's just whether you can do that in a safe manner. Like, can you actually get a patient to single leg 2 times body weight press the leg press in a gym setting? That's a really crude measure, but that's probably what I'd look at. Not anything less, because arguably then your hip extensors, quad, hamstring are nowhere near strong enough to actually tolerate the demands of running and jumping. Then on a seated, so it's like a Smith machine, for example, we used to take around 1.3, somewhere in the zone, it's not an exact number, but sort of in the zone of 1.3 to 1.5 times body weight of a seated calf raise. And so I think that's got some relevance again from the tendon world. That's where we got it from. And it actually works reasonably well, because you see a number of athletes from a soleus function are just way below, like they can't get anywhere near their body weight, let alone 1.3 or 1.5 times body weight. And then from a leg extension function, can someone isometrically hold 70% of their body weight? That's what we've used in the past, and it tends to work, again, as a bit of a crude measure pretty well. It's just all on the safety, I guess, of the setup. If you can sort of lock the machine, or you can get the pin to actually, you could probably even on a leg extension get sort of 2 legs up, 1 leg back, and safely do it. Yeah, possibly that's a way to do it. Some people will be strong enough as well, though, to push through 70% of their body weight on the leg extension. So they're probably the three key areas I'd use in a gym setting with no technology.
Cool. Yeah, that's great. Okay, mate. Last one. I've held you long enough. Last question, but it's more probably around some research you're doing now, which I've seen, and it's really interesting. And I believe, obviously, you're doing some stuff still in the ACL field with the development of some more recent technology and AI, and as a feature of this. And I guess that falls in with some of that more recent research that you guys are sort of doing at the moment that I've seen certainly out there. It's coined, and you're the lead author. Is it time to develop specific return to running criteria for ACL rehab? It's an international survey of physios criteria for return to running from ACL injury. So there's probably two research projects there and how they come together, but just a bit of an idea on, I guess, what you're looking at here moving forward and what we might be able to expect from you in the research world coming out soon.
Yeah, so the study we did with the survey was really just to have a look at what people use globally as physiotherapists for return to running. And essentially what we showed was that there's no real consensus on what people use. There's the sort of typical things of pain and swelling and range of motion. But what we wanted to really find out was, do clinicians actually consider more than just the clinical symptoms? And particularly with technology, do they actually maybe know what they're looking for specifically? And we obviously had to summarize that in a research paper, but from the raw data, it was literally all over the place. Like, there was people using symmetry indexes of 60%, 75%, 90%. Some weren't even using them at all. Some would use like really crude measures of leg extension or leg press strength, as I mentioned before, that had no like peak force output at all. They would just, again, maybe compare leg symmetry or athlete symptoms. So we purposely sort of did that study to scope, again, what were people using, and we suspected that there probably wasn't any consensus. If you actually look at the literature, a lot of it just basically shows that there's a lot of return to running programs to try to see if that works, but no one's actually gone back to actually develop a criteria in the literature for what would be sort of the key metrics that you have to achieve before you go run safely. That's kind of the area that we're looking further into now. And I guess with the question regarding AI, we work closely with Springbok Analytics, which is a really unique and valuable company in the sense that they've created an AI platform for muscle tissue volume. And so we essentially are trying to quantify and look at tissue volume in ACL patients prior to and following surgery to really start to characterize how much tissue volume do they lose and of which muscles, because this system from Springbok basically can go from the pelvis all the way down to the foot. So we get every lower limb muscle. And I think that's going to have insight when we pair that with muscle function, so the strength tests that we've talked about, and then extend it even further to some of the human movement or sports-related tasks. And that in itself, I guess, will start to allude as to how much function do we lose? Is muscle volume important? Because we actually don't know. We obviously appreciate we have atrophy, but it might be that certain percentages of or loss of tissue for certain graft types, because we're extending this to hamstring and quadricep graft, which are quite common now. Maybe one of the graft types doesn't work as well. Maybe there's a different sort of, from a rehab context, a different amount of volume that's in different muscle groups as an adaptation. And maybe that functions as a different metric in terms of strength as well. So that's kind of sort of part of the pathway we're going down in terms of running and, I guess, tech.
Nice. Yeah, I've been privy to have a look at the Springbok a couple of times through some athletes, and it's interesting. It's certainly an interesting space to keep an eye on. Mate, fantastic chat around ACLs and tried to and hopefully target a little bit more towards the female athlete, because I certainly am aware we haven't talked about too much in our education component. So I really appreciate you jumping on board. If I want to have you look at an athlete or a patient, I can do that, and can't I? And I could probably just reach out, give us a little a spin on the practice or clinic in Melbourne and where we can reach out to you.
Yep. So we're centred in the centre of Melbourne in Queen Street. The clinic's called Melbourne CBD Physiotherapy and Sports Medicine Clinic. And we do, yeah, as I said, a bunch of consulting for elite athletes, but also, like any practice, see regular patients and sort of utilise our technology in terms of the systems that we've purchased for I guess, evaluating at a bit more of a comprehensive level.
Nice, mate. I love it. Thanks heaps for your time and appreciate you jumping on board.
Thanks, Nick.